So thank you very much for participating to the webinar, and welcome to this first webinar of the Reverse project. We will wait another 2 to 3 minutes. We are still a bit ahead of time, so we let everybody log in. So just a minute, please. So it's Tuesday. My name is Walter Zink. I'm the coordinator of the Reverse project, the Horizon 2020 project on emerging antimicrobial resistance. I would like to welcome you to this first webinar of Reverse on the prevention and management tools for reducing antibiotic resistance in high prevalence settings. I would like to hand over now to Dr. Sasha Cerno, who is the project manager of this project, to lead us through this first webinar. Please, Sasha.
Thank you, Walter, and also welcome from my side. As you can see here on the slide, we have today 3 speakers, which are Professor Dr. Mark Strulens, Professor Dr. Yehuda Kameli, and then Walter Zink as the third speaker. So very interesting talks. If you have any questions during the presentations, we would like to ask you to just write your questions in the chat. You should indicate then obviously for whom the question is, and then at the end of the presentations we will have a Q&A session until 4 p.m. Central European Time. Any additional or unanswered questions then in the end that we didn't get to, you can also send to our Reverse email address, which is reverse@usz.ch. And then to start off the webinar, I would just like to introduce Professor Dr. Mark Strulens, our first presenter. Mark is a professor emeritus at the University Libre de Brussels in Belgium, where he also was a professor of medical microbiology at the Faculty of Medicine from 1997 to 2019. He was also the head of department of microbiology at the Erasmus University Hospital, and also the head of the infectious disease epidemiology unit at the School of Public Health until 2009. And maybe many of you also know Mark as the chief microbiologist at the European Center for Disease Prevention and Control, where he was serving that position from 2010 to 2020. Mark has authored or co-authored more than 300 peer-reviewed articles and 25 book chapters, and has received multiple awards, for example, the award of the Belgian Society for Clinical Microbiology and Infectious Diseases. And he was also elected the Fellow of the Society for Healthcare Epidemiology of America and of the European Society of Clinical Microbiology and Infectious Diseases. So welcome, Mark, and we're looking forward to your presentation. I would then hand over to you, and you can then also share your presentation.
Thank you very much, Sasha, and hello everyone. It's a pleasure to have the privilege to introduce the webinar today and set the scene or where we stand today fighting AMR within the healthcare system, and the way forward, at least some indication where we could go with research and development projects such as reverse, as well as public health mobilization. Do you see my screen now, Sasha?
We can see your screen, but not in presentation mode.
Right. Is it better now?
No, you probably have to unshare and share again, then your presentation mode.
Okay. Let's try that again. Is it full screen now?
Perfect.
Thank you. First of all, I'd like to state that my talk today is my personal opinion and not the European Union official position. So if you look at the current trends in both antimicrobial consumption and resistance across Europe, especially the European Union and associated countries over the past 20 years or so, there are some good news and some trends that show that there have been some successful modification of prescribing behavior, especially in the community, with decreased consumption, for instance, of expanded spectrum cephalosporins and some stabilization in the hospital sector, except for last resort drugs such as carbapenem, which have increased and maybe stabilized over a few years now. If you look at the parallel trends reflecting the selective pressure from some key pathogen resistance to the same drug, the third generation cephalosporin, for instance, we can see that there's still a rising trend, but a bit slower over the past few years. But for Klebsiella pneumoniae, this plateau is still quite going up. So especially with healthcare-associated pathogen, we see forthcoming continuation of the increase in that prevalence of resistance across Europe, which remains a problem. More recently, as we just completed the World Antibiotic Awareness Week and European Antibiotic Resistance Awareness Day, we could look up at the very latest update from data in Europe, the ESNet and CSAR surveillance program. And the short news indeed is that the population mean percentage of carbapenem resistance in both E. coli, which is quite new, and Klebsiella pneumoniae, as well as VRE in blood isolates, is showing still a continuing significant increase over the past 5 years. So this is really still an ongoing problem. And a landmark paper was a paper from Cassini et al. A couple of years back now, looking at the data again from European-wide surveillance ESNet for the EU countries, and trying to estimate the burden in disability-adjusted life years that's directly caused by the 5 main kind of clinical infection with antibiotic-resistant bacteria in the EU. And they came up with over 650,000 cases of such infections within the rows, out of which an estimate around 33,000 could be directly attributed to the infection to be a fatal outcome. And 3/4 of that burden was coming from healthcare-associated infection again. And the graph to the right indicates the burden by pathogen and by country. And you can see that there's about 10-fold decrease from countries such as Italy, Greece, Romania, Portugal, for instance, in the top league, and that the multi-drug resistant gram-negative to third generation cephalosporin in orange and in green to carbapenem were leading again the burden in terms of DALYs as well as attributable death. So a substantial health burden on an annual basis. And what is driving, of course, this burden and acquisition of resistant infection is also the not just the proportion of resistance, but the transmission within hospitals and between hospitals to various degree of epidemic dissemination. And Ayo Grunman, a few years back, developed a staging for this degree of epidemic dissemination from sporadic to single hospital to multiple hospital or interregional spread from green to dark red or even brown. And you can see there is this north-south-east gradient in the degree of dissemination. But in fact, even countries with low prevalence of carbapenem resistance, for instance, Klebsiella pneumoniae, do face a quite widespread transmission in the healthcare system. So control is of paramount importance. There are also good signs in moving forward across Europe with capabilities of microbiology services, both at the hospital level as well as reference lab level, to improve the consistency and accuracy of AMR detection. And that's the first panel to the left, looking at some scoring of the national system for AST, susceptibility testing methods. And this is essentially the alignment across laboratories to the case definition of resistance and methods promoted by UCAST. And to the right is more the national public health capability for monitoring through national surveillance, including molecular monitoring of resistant determinants and clones across hospitals, as well as the national response support to regional or local outbreaks for AMR and other epidemic disease, which gradually improve, but far from being on the top level across all of Europe. This is mean of all the EU countries, but again, there is much disparity between countries. This is just an illustration how standardization of laboratory practice has now gone to a large extent. Over 90% of EU countries and a large proportion of neighboring countries have 90% or more of the clinical laboratories performing according to UCAST standards and guidelines, which is making more comparable and reliable data being reported not only to clinicians first and foremost, but also local infection control team, national surveillance program, and European and global surveillance database as well. But this has had to be complemented, counting proportion of resistant and susceptible isolates or infections caused thereof, by monitoring at genomic level what are the genetic population structure of these bacteria and the transmission dynamics. And ECDC organized a few years ago a complementary European reporting and surveillance system called EurogenNet, which is coordinating right now a pan-European survey of carbapenem colistin-resistant enterobacterialis, mostly Klebsiella and E. coli, and also performing ad hoc rapid risk assessment of emergent extensively resistant organism outbreaks. And I'll illustrate a few in this presentation. The first structured survey, which was done in 2014 by the a consortium of reference laboratories in collaboration with ECDC, and then was later subjected to whole genome analysis, confirmed that Europe was largely a part of the international spread of one particular successful carbapenemase KPC enzyme in Klebsiella pneumoniae, and especially one long-established clone, ST258512, which in phylogeographic analysis of selected genome in the public domain was already present and spreading across the USA 20 years ago, then when spread over the Atlantic to Europe in countries like Greece and Israel, and also during the 2014 survey was spreading very fast in its 512 variant in Italian hospitals. So international spread was clearly shown in that particular strain of Klebsiella. But what's also important looking at the cross-sectional survey is that the clones carrying KPC and other carbapenemase enzyme would mostly cluster within hospital, indicating excess of nosocomial transmission as the main driver of the prevalence of carbapenem-resistant infection in those hospitals and countries, followed by the inter-hospital spread and to a lesser degree international spread. The same exchange of epi and genomic data has allowed to explore also more recently the mechanism by which less common carbapenemase, the NDM1 and OXA48 enzymes are spreading across Klebsiella pneumoniae strains in Europe. And this is a study published last year where 10 countries reported 15 genetic clusters of Klebsiella carrying either of these enzymes. And to the left are the number of cases with these type of resistant Klebsiella in these countries. And to the right are the country of travel in the previous 6 months for the patient in which these resistant strains were detected. And for instance, from countries like UK and Germany, it was mostly within the country or within EU travel. But for many other countries, this was associated with travel to further afield countries in North Africa and the Middle East, as you can see there, Egypt and Tunisia, for instance. So there's still ongoing cross-border dissemination of emerging carbapenem-resistant clones and genes that we have to be aware of. Along the same scenario, now the worrying increase of carbapenem resistance in E. coli, which used to be very low level, is significantly increasing. And this is one of the driver that's been recently characterized again through Eurogenet data exchange with the CDC. In this case, there's the presence of OXA48 derivative, OXA244, which is hard to detect and may turn out not to be expressed and be classified as clinically susceptible by UCAST routine breakpoints, but nevertheless may not respond as well to carbapenem therapy. It's not very well known. And the past 2 or 3 years has been increased in number of countries of these particle isolates that, again, by genomic analysis do cluster in the same lineages, and again, add some association with previous stay or hospital care in North Africa or Middle East. So again, continuous feeding of difficult to treat organism through travel and hospital transmission. And the last example of that kind of fast changing dynamics of clones is the emergence also in Europe of the hypervirulent carbapenem resistant strains of Klebsiella pneumoniae. And one particular lineage that was known from more than a decade to cause severe disseminated infection with liver abscess and other metastatic foci of infection, K1ST23 clade, has also now been found more frequently in the past few years in European countries and with diversity of genetic variant, but a conserved profile of hypervirulence determinants. So quite a superbug combination of pathogenicity and extensive drug resistance that makes this particular strain of particular concern. Moving from where we stand in containing transmission and preventing infection with healthcare-associated strains and drug-resistant strains of gram-negative and others, we have, of course, to go back to the seminal study on effectiveness of general IPC program at hospital level that Walter Zing and colleagues, together with a panel of experts based on systematic review of such intervention, had published. And this recap the structural aspects such as a proper organization of infection control services, but also management of adequate bed occupancy and adequate staffing to manage the workload, access to proper materials and equipment and ergonomics to use them properly, use of guidelines, staff education and training, auditing, surveillance feedback to ensure that all components are properly taken care of and corrected if need may be, And importantly, also, it came out from that review and supported by the experts that multimodal, multidisciplinary prevention bundles and program, including behavior change and leadership, were essential, and generally a positive organizational culture to improve patient safety were of paramount importance as an ingredient. More specifically for carbapenem-resistant Enterobacteriales and other gram-negatives, there have been a number of evidence-based guidelines and consensus recommendations as well that cover this multiple intervention that were referred to in the previous paper. First and foremost, prudent antibiotic use and stewardship program, and high level of hand hygiene compliance by all staff, as well as more technical procedures such as active screening, rectal or multi-site, especially of patients admitted to high-risk facilities or coming from other healthcare settings or institutions. Preemptive isolation, colonized patient isolation, cohorting, contact tracing, and especially for the aquatic organism, I'm sure the next speaker, Yuda Kameli, will elaborate on that, such as Acinetobacter, also environmental cleaning, decontamination, and again, the overall use of continuous staff education, auditing, and feedback. Not all these components necessarily should be implemented. For instance, active screening had mixed results in various studies. This is from one particularly well rigorously conducted multi-center international intervention study, the Mozart study, published a few years back, which showed that in this particular ICU setting, the MDRO followed at that time endemic to this ICU, such as MRSA and ESBL, were not further reduced in transmission after high level of hand hygiene and systematic chlorhexidine body wash of the patient were implemented. So again, such intervention need to be tailored to the local epidemiology in the context of multiple more horizontal intervention. And a review more recently updated on such systematic quasi-experimental interventional study and systematic review and reanalysis led to the conclusion that multimodal intervention with over 3 components were generally highly effective, and that the general lessons learned was again that specific ingredients for each of these packages had to be considered in the context of the local needs and capacity, so the so-called tailored implementation of such interventions. An example of a recent application of this philosophy, a 5-component infection control bundle to permanently eliminate a carbapenem-resistant clone of Acinetobacter baumannii spreading in ICU by Mescari et al. Published this year, showed that during a long period of several years here of improving hand hygiene, and this is the alcohol consumption increasing, an antibiotic stewardship program reducing the prescription of both carbapenem and fluoroquinolone in this particular ICU, did not stop the blue line here, peaks of transmission of CRAB, carbapenem-resistant baumannii, unless and until they introduce a very stringent environmental cleaning and patient decontamination, and then sustain and intensify all the same package of intervention with this high meticulous cleaning of the environment. And that eradicates the no more blue line cases of ICU required, only imported cases of CRAB were noted. So sometimes you have to try and improve as you go along to get the right combination. This is more kind of the bad news, that even if you're successful, as this report from a Greek hospital on, again, multimodal IPC intervention that were then showing effect, but which were reversed after a shortage in staffing level, and resources in general were introduced due to economic recession. And compared to baseline, the introduction of bundle decreased the incidence of carbapenem-resistant gram-negative, but there was in the following 2 years a rebound back to baseline in the incidence of such infection. And this was closely associated with the decreased attendance to educational session, the decreased compliance with hand hygiene, as well as the intensive, of course, use of blood culture to ascertain those cases. So indicating that the reduction of resources were really, unfortunately, undermining the effectiveness of infection prevention and control interventions. So to conclude, I think we are making progress, and it's possible to manage and prevent AMR within the healthcare environment. And the way forward is to build upon success that have been achieved by improving further antibiotics use, IPC, and good laboratory practices, networking among hospitals to deal with the transfer of patients and organisms with them, and integrating with public health to have an overview of the situation and support where outbreaks get out of hand. Real-time genomic surveillance for tracing both AMR gene and ARO clones and resolving its complex epidemiology is making progress, is becoming more available and more frequently used. And this in the context of this One Health approach and awareness of multiple reservoirs that go beyond your own hospitals to deal with. The important lessons learned from recent history and previous year recession and COVID pandemic, that fiscal policy, external pressure on resource versus patient workload can really make life too difficult to ensure a proper patient safety, including AMR control. At the European level, we really need now the implementation of multi-center, well-defined, well-monitored, integrated intervention studies in endemic settings. And this is what the reverse action is tackling, and is very timely and important step. Beyond the research per se, I've shown that we do now possess communication platforms, so EuroGenNet, to help detect the multi-country dimension of national outbreaks and respond to such alerts in a timely manner, and not when this has been revealed 10 years later by a nice publication. And post-pandemic public health capacity is recognized a priority for many EU programs and the new EU budget with the EU for Health new program, which is about 20-fold more generous than it used to be for public health in Europe, and some technical investments such as the HERA that is now supporting in the level of 300 million euros over this year and next year in building capacity for genomic surveillance for COVID, but also potentially other pathogens such as MDROs. And on this note, I will stop here. Thank you for your attention.
Thank you, Mark, very much for this very interesting presentation. As I mentioned in the beginning, but now we had a few more visitors joining the talk. You can ask questions in the chat or the Q&A function that we then try to answer towards the end of this webinar. Please also indicate for whom the questions are meant to be, so that we can more streamlined, obviously, answer your questions. Our next speaker, our second speaker, is now Professor Dr. Yehuda Carmeli. He is a professor in medicine at the Sackler Faculty of Medicine at Tel Aviv University in Israel, and also the founder and head of the National Institute for Antibiotic Resistance and Infection Control, which is situated at the Tel Aviv Medical Center, which is conducting nationwide infection antibiotic resistance control interventions in Israel, including also successful interventions to contain CRE outbreaks in acute and long-term care hospitals. And obviously, since this webinar happens also in the framework of the Reverse project, we have to mention that Yehuda is also currently co-leading one of the work packages, work package 3 on infection prevention and control in this project. Yehuda was one of the first to warn the medical community on the global risk of CRE and participated also in the writing of several guidelines on limiting the spread of CRE. Yehuda has authored and co-authored more than 350 peer-reviewed articles, as also recipient of multiple research grants and awards, and member of the editorial board of major journals in the fields of infectious diseases and antibiotic research. So we're very happy, Yehuda, that you could join us today and present a very interesting talk on also the experience you made through other research projects on NDR, Actinobacter baumannii, epidemiology and control. Thank you.
Thank you very much, Sasha, and it's a great pleasure to be here today. As mentioned before, I was involved and I'm still involved in CPE control in Israel. But when I was a student, one of my, I would say, admirable professors told me it's better to speak on your failure rather than your own success. So I've decided to speak on multi-drug resistant Acinetobacter baumannii and speak about epidemiology and control. And I'm not sure that I'm able to move the slides. Okay, so Acinetobacter baumannii infection have a great geographical variability. Some countries have very low levels, some countries have very high level. In certain ICUs, it is as frequent as Pseudomonas aeruginosa, and even more so as the cause of bloodstream infection and ventilator-associated pneumonia. And for Acinetobacter baumannii, multi-drug resistant is the rule. Again, there is some variability about carbapenem resistance with rates varying between 40 and 80% of carbapenem resistant among Acinetobacter baumannii. And I'm shameful to say that in Israel, we're at the 80% level. And the virulence of the organism is variable. It tends to affect severely ill patients after prolonged hospital stay, mostly in the ICU. About 80% of the patients are either mechanically ventilated now or have been mechanically ventilated in the past, have been exposed to multiple antibiotic agent, and some of them had surgery before. A unique group is trauma patient, mostly after mass causality or combat injury, where younger patients and healthy patients are involved and have early infection, but that's a whole different story, and I will not speak about it today. It's an interesting story by itself. As you see here, nosocomial bloodstream infection, Acinetobacter baumannii, time from admission, you see at the bottom of the list Acinetobacter baumannii with median time to infection of about 25 days. So it's a very late infection in most of the cases. As the organism become more and more endemic in your setting, the infections become earlier. Carbapenem-resistant Acinetobacter baumannii bacteremia, CRAB, we'll call it for now, is actually a very fatal condition. And you can see here on the left-hand side, the 14-day mortality is 50%. If you go to 28 days, you can reach even 70% case fatality rate. And what you see on the right-hand side is that fatality differs by the different clones, and some clones have much higher virulence than others, leading to higher rates of mortality. The epidemiology of Acinetobacter of carbapenem or multi-drug resistant Acinetobacter baumannii is variable. The classical epidemiology is clonal outbreak, and this is a report from the late 90s in New York City, where 15 different hospitals had a clonal spread of the same clone that spread between hospitals. and via colonized patients and healthcare workers, led to contamination of environmental surfaces and caused hundreds of infections in those 15 hospitals. So a classical clonal spread, regional spread. Another example is a web producing Acinetobacter baumannii that spread in the early 2000s in France, and within 15 months affected 53 hospitals, 275 clonally related A. baumannii were isolated, and there was an inter-hospital spread associated with patient transfer. So classical transmission across setting and regions. What you see here is that once Acinetobacter is introduced, it's very difficult. It may spread rapidly and may be very difficult to eradicate. So here you see an example in an ICU. 2 imported cases resulted in 84 acquired cases. And what was happening every time you succeed in your infection control, there is reintroduction of colonized patients, and again, a second round of transmission. This has led in Israel, that's, as you see, late 90s, early 2000s, Acinetobacter baumannii became very prevalent in many Israeli hospitals. Look here at some hospital reach 80 new cases per every 100,000 patient days. So enormous number of cases, and there was a steep rise. At that time, there was no investigation of the molecular epidemiology of that, but that established endemicity, and at that time, about 50% mortality was associated with those events. When we speak about patient transfer and introduction into the hospital, we have to remember the long-term care and post-acute care setting, because crab can be imported and exported from hospitals to post-acute care facilities and form a vicious cycle of transmission and amplification. Each facility has its own epidemiology, however, they feed each other and maintain transmission by introduction and reintroduction of carriers. So what we can take from that is that to effectively control crab, you need a coordinated regional intervention, which includes both acute and post-acute care facilities. It's quite difficult to control Acinetobacter baumannii. This is a multifaceted intervention that we conducted in the 2005 at Tel Aviv Medical Center. At that time, we conducted a very high-level campaign of hand hygiene, of isolating patients with resistant organisms, improving control, really engaging in the entire hospital administration and hospital staff. And you can see it was extremely successful campaign and project to reduce Clostridium difficile, reduce MRSA and VRE, but had relatively minor effect on Acinetobacter. The other important point to see here is that multi-drug resistant Acinetobacter baumannii was the most frequent acquired MDRO at that time and the hardest to control in Tel Aviv. So when beyond vertical, so if beyond horizontal measures, as I mentioned in the previous slide, we can use vertical control measures, organism or mechanism specific measures. And when you apply those, it's important to understand the epidemiology and then find ways to accurately and rapidly identify carrier, separate them from all others to reduce transmission, either by isolation or by cohorting. And you need to place them into dedicated location, equipment, and staff if possible. And based on the specific organism, also have enhanced tailored cleaning. Decolonization and suppression of the organism to prevent spread. And for Acinetobacter baumannii, the only thing that we may think of is chlorhexidine wash, but that's not a done deal whether it's helpful or not. And then, as was mentioned before, reduction of antibiotic use is important, but often quite difficult to perform. And formulary intervention, replacing one agent with another, it's very unclear if it's helpful, especially for Acinetobacter baumannii. So we looked at the epidemiology of multi-drug resistant Acinetobacter in Israel at that time. And to our surprise, we did not have the monoclonal outbreak as I described before, but we found polyclonal outbreak. Polyclonal outbreak, which means there was no time and space clustering. We found multiple clones with 2 more frequent clones, but truly we had outbreaks, but polyclonal, which is a very strange condition. So we conducted studies trying to understand that, and I think that's it's quite complicated study to understand. I will try to show it here, and I'll take you to the conclusion, which is more important. So what we have done here is over a period of 4 months, we collected all Acinetobacter isolates and typed them, and we looked at all patients' movement throughout the hospital, consultation, exams, and so on. And what we found, what you see here in orange or brown, is outbreaks, what we called having more than 2 cases within 2 weeks. And what you can look, and you can see we had multiple in multiple wards. On the one axis is the week, and on the other axis is the different wards. And what you can see in the bottom is an enlarged part of the time course in surgery 2. And you can see that we had cases almost every week. But when we started, we had the first week, we had 3 cases, 3 different clones, clone A, clone C, and clone G. Next week, we had C, so okay, it's linked. Then we had a week with nothing and a week with D. So if you looked at that, that's a polyclonal outbreak. However, if you look at the longer time point, you see that A repeats himself multiple times, and C repeats himself multiple times, and D repeats himself multiple times. And when we looked at what we call transmission opportunity, did patient with clone A meet patient with clone A, and patient with clone B met patients with clone B, we found that actually if you have the full picture, so that this last 7 weeks of the study that we knew who's colonized with what, 12 of 12 patients had transmission opportunity of meeting someone either in the same ward or in the same exam room or having the same consultant on the same day as another patient with the same clone. So we concluded that transmission is the rule and the polyclonal outbreak are parallel outbreaks of several clones. When you look at the dynamics of Acinetobacter baumannii in the hospital, described here in Nature Microbiology more than 10 years ago, and you can see the classical examples of staff transferring the organism by their hands and dirty clothes. You can see some equipment, And you can see some machines that can transfer, be the source of the organism. When you look at the right-hand side, I want to point out that's from one of the studies we have done on environmental contamination. And you can see here, when you look at the patient sheet, on the bed rails, cabinet, monitors, ventilator, feeding pumps, infusion pump, or, in each of them, you'd see extremely high contamination rate. So above 60% or 57% for each of these sites that we sampled. So the rule for for multi-drug resistant Acinetobacter is environmental contamination is very common at the patient area for a colonized patient. And because of long survival in the environment of the organisms, even after the patient leaves the room, the organism may stay for a very long time. So how do the organisms get to all these parts of the room? So partly, it's of course by patient movement, but many of these patients are bedridden, and by the hands, the contaminated hands of staff, but partly is by droplet aerosol spread. So, now with COVID, we all became experts in air transmission and the disputes about it. But actually, when you look at air dispersal by crab, we measured it either by air capturing machine or by plates in different places. If you go up to 2 meters from the patients, you can find a lot of dispersal of crab for patient in the air. So what happens is that when there is no activity in the patient room, 3% of the time there is, you can isolate carbapenem-resistant Acinetobacter baumannii in the air, so very little. But when there is activity in the patient room, up to 50% of the time, you can find carbapenem-resistant Acinetobacter baumannii. And what are the activities? The activities differ from each other. For example, performing open suction, open endotracheal suction from a patient leads to high burden of air contamination by crab. And when you change the bed sheet, exactly the same, again, high load of organism in the air, and those organisms fall and remain and contaminate the surrounding. So that's something we have to take into consideration when we think about control measures. So what about environmental contamination and cleaning? So those are 2 studies that looked at that. Pre-cleaning, 47% of the room and 15% of all sites tested were contaminated by Acinetobacter baumannii, so terrible. But then post-cleaning, still 25% of the room and 5% of the sites were positive. And they became, only after 4 rounds of cleaning, 16% of the room and 2% of the sites were still positive for Acinetobacter baumannii. There are issues with emerging technologies, vapor and mist. I will mention it in a second. So what we have done is we said, okay, we'll train our staff to clean better. And so what did we find? Before training, 78% of the objects or the sites that were sampled after cleaning were still crab positive. Then we did refresher training. We told them, how to clean appropriately. And they knew that we are testing them. So after training, 39 of the objects sampled after cleaning were still crab positive. So what is that? How can that be? We saw them cleaning. They did what they needed to do. So what we found is that when you look at, you do fluorescence gel cleaning versus environmental culture, you find that in many cases, the fluorescence gel marker disappears, but the cultures remain positive. And that actually shows that the quality of the cleaning, meaning how wet are the cloth they use with disinfectant, and how thoroughly they do it, is important to note. And fluorescence gel may not be enough to judge appropriate cleaning. That's an example of adding peroxide to supplement cleaning. And here in this study, they found that it had excellent effect in helping them to stop an outbreak. We have looked at that, and I can say that it's very difficult to measure the effect. If you do perfect cleaning, manual cleaning, you don't need supplementary material or supplementary techniques, because sometimes, or most of the time, the cleaning is less than perfect. It may be helpful to have a second supplementary technique, such as UV light or peroxide vapors. It's quite difficult and expensive to perform. It requires time, it requires emptying the room and so on. Not always very practical, but we have to remember it as an option. So moving from cleaning to detecting carriers, as we mentioned, detecting carriers is important in using vertical measures. And for many years, we did not have good methodology to detect carbapenem-resistant Acinetobacter baumannii carriers. What we have shown here in several studies, but that's the largest and the most recent one, we summarized the data, and what we found that the body sites that is best to test is the skin. It detects 91 or 92% of all carriers detected by multiple site testing. If you add to the skin also the buccal mucosa, you reach 100%. And most of the lab don't want to do skin testing, and I'll show you why in a second. So many use buccal mucosa and rectum, and you have to remember that that will give you probably only 70% of the cases, and probably is not good enough for good infection control practices. So how do you sample the skin? So the problem is that to do a good skin sampling, you need sponge, special sponge. If you use swab, the sensitivity per site is quite low, 20 to 50%. If you use sponge, you get to 70 to 80%. And if you use the sponge, as I mentioned before, and we reached 91%, 92%, is because we combine the sponge with enrichment and special chromogenic plates that select for MDR Acinetobacter, and that both increases the sensitivity, as I mentioned, the time to results, and ease of work. But most laboratories are not used to work with sponges. They want swabs. So you have to negotiate it with your microbiology lab to use swab if you go for it. Another question is, once you detect a carrier, how long should he be considered a carrier? And this is not a closed question. I would say that as a working assumption, we chose, based on several studies, this one is one of them, is that shows that after 6 months from the last positive culture, your chances of being a carrier is probably less than 10%. And so we suggest that a CREB carrier should not be considered non-carrier until 6 months has passed from his last positive culture. What about interventions? And that's a study from Israel, from Jerusalem, where you see in red the occurrence, the number of patients with CRAB in the ICU in red, and in the entire hospital in blue. And you can see that there is an ongoing endemic situation. Where the black line crosses, it's actually they did an intervention. The intervention included removing screening for carriers, removing all the carriers from the ICU, thorough cleaning of the ICU, returning the patient, the colonized patient, into a cohorted area, separated area with dedicated staff, and then twice weekly surveillance screening of the ICU. And you can see that that was a very successful intervention, quite difficult intervention, but successful, almost terminating the outbreak in the ICU, but also beyond that, having a large effect on the entire hospital, which they interpreted as identifying that the ICU was actually a ward generating cases that were transferred to the entire hospital and leading to outbreaks in different locations. That is my best intervention I can propose. That's from Thailand. As you can see here, they had an endemic situation with carbapenem-resistant Acinetobacter baumannii, and they did various intervention, implementation of infection control, education programs, and so on. And they had some success, but really not great success. Then there was a big flood in Bangkok. All of us heard about it, and the hospital was flooded, had to be evacuated, have to be repaired, and after they re-inhabited the hospital, Acinetobacter was gone. So that's, if you're looking for an intervention, suggest to your hospital director to flood the hospital. So when it's not possible, many times we cannot close wards. We hardly ever close wards to overcome an outbreak. We don't have enough spare wards, and especially not ICUs. So what do we need to do? We need to detect carriers, strict isolation, including protection from dispersal by air. Closed suction system, we recommend closed suction system to reduce environmental contamination. Enhanced cleaning, and we most of the time recommend skin disinfection by chlorhexidine, but that's not a closed question. And what you can see here that the same hospital that I showed you before, that's a number of new cases, acquisition of Acinetobacter baumannii per year. And you can see that when we, at one point we started actually before, but at 2009, we had more than 400 episodes a year. And by multiple, intervention, I would say trench war, where you cannot conquer anything, but you conquer each time a small part of the land. We reached up to now 150 or so cases per year. So that was multiple interventions, multiple wards, and trying to reduce Acinetobacter baumannii. So you can succeed, but it takes a long time. It's a marathon run. And on the country level, we are conducting a country level intervention, and you can see here that the intervention truly started in 2014, the country level intervention. And you can see that number of cases of bacteremia per year. And you can see that we went down from close to 650 cases per year to about 300 cases a year in 2020. So more than 50% reduction in crab bacteremia over 6 year time. Not a win, but I would say still a success. So I'd like to summarize here, Acinetobacter baumannii infections are emerging in many hospitals. Always, it's a nosocomial outbreak. Don't think about it as a non-outbreak when you have few cases in a hospital, even if it's polyclonal. Endemicity is multiple concurrent outbreaks. It's truly not an endemicity. It's just multiple outbreaks. You can fight with them. Control require rapid response, identifying carriers and contact tracing, effective isolation, enhanced environmental control, and environmental source detection and elimination if possible. When endemicity is established, understanding the local epidemiology, identifying wards which serves as generator, and continuous effort is required. Thank you very much.
Thank you, Yehuda, very much for this very interesting overview. Our last speaker today is Dr. Walter Singh. So Walter is the head of the Infection Prevention and Control Program, and also consultant in infectious disease at the Clinic for Infectious Disease and Hospital Hygiene at the University Hospital Zurich in Switzerland since the end of 2020. Before his appointment in Zurich, he was a senior physician and consultant in the Infection Prevention and Control Program at the Universal Hospitals in Geneva. Next to his appointment in Switzerland, he has an academic affiliation with the Charité Hospital in Berlin since 2019. And he is currently coordinating the REVERSE project and is also the work package lead for work package 1, which is dealing with the main clinical study of the project. Walter has authored or co-authored more than 100 peer-reviewed articles and 6 book chapters. He has also received multiple research grants and awards. For example, he also co-coordinated the EU-funded project PROHIBIT on prevention of hospital infections, prevention and training from 2010 to 2014. He is a current board member of the Swiss Society for Hospital Hygiene and also serves as an expert regularly for the ECDC and the WHO. Walter, I would hand over then to you. Walter will present a bit of background and also some information on the REVERSE project.
Okay, now it's good. For some reason, I didn't have access. So thank you very much. I would like to make a short introduction of what REVERSE is. REVERSE stands for the Prevention and Management Tool for Reducing Antibiotic Resistance in High Prevalence Settings. This is a mixed methods project in 24 acute care hospitals in 4 European countries. 4 countries with high prevalence of multi-drug resistant microorganisms. So some background information. HAI, healthcare-associated infections and antimicrobial resistance. So 3.8 million patients acquired a healthcare-associated infection each year in European acute care hospitals, as assessed by the first ECDC point prevalence survey. And antimicrobial resistance to selected markers was almost 32%. So when we compare the 4 countries, we are Greece, Italy, Romania, and Spain to Switzerland, and we think about healthcare-associated infections, and we think about antimicrobial resistance, we have the following picture. So let's start with the prevalence. In Switzerland, in 2017, we had a prevalence of HAI of 5.9%. Greece had 10, Italy 8, Spain almost 8% as well, Romania a bit less. This may have been due to some methodological issues, I don't know, but probably higher. All the 4 countries where we have have higher HAI prevalences compared to Switzerland. When we assess the incidence, basically this a similar picture, however, not quite the same. So because it depends largely on length of stay on patients in the hospitals, there we have a little bit more, let's say, equal picture across the countries. But definitely, when we look at the resistance situation in those countries, carbapenem resistance E. coli, still relatively rare, but you can see that in Spain and in Greece, it is a bit higher compared to the other European countries. Carbapenem resistant Klebsiella pneumonia, then we certainly are at the right spot, particularly Italy, Romania and Greece have high levels compared to the rest of Europe. Carbapenem resistant Pseudomonas aeruginosa, same picture, especially or particularly in Romania and also in Greece, we have high proportions of carbapenem resistant Pseudomonas compared to other isolations of Pseudomonas aeruginosa. And when we talk about CRAB, the carbapenem resistant Acinetobacter baumannii, as we heard Misrel there as well, reverse really operates in 4 of the high prevalence countries in Europe. Method MRSA maybe a bit less of a focus right now, but still we should not forget because it's still there. And also there we can see that especially in Italy, Romania and Greece, it's still higher compared to other countries, certainly compared to Switzerland. And VRE, maybe not so much of a on the radar right now, but maybe also because we do not often have it on our surveillance radar, but still out there, and also higher proportions in countries where we operate. When we take all those resistance or bug resistance combinations together, and then we talk about what is called a composite index, as we reported by the ECDC, it is a combination of MRSA, VRE, then Enterobacteriaceae resistant to 3rd generation cephalosporins, Pseudomonas aeruginosa, and Acinetobacter baumannii resistant to carbapenems. It is the proportion of resistance in those pathogens together compared to the total of isolations. This data is coming from the point prevalence survey. We can see that actually Switzerland had 16%, but the countries we operate, Greece, Italy, Romania, are almost 4 times higher than Switzerland. Only Spain is a bit lower, and Italy is a bit lower as well. This has been shown already by Mark Strelens, and it shows you the burden. And what's interesting here is that when we look where we operate, we operate at the top 3 countries in terms of burden of antimicrobial resistance, particularly in gram negatives. What's really interesting here, it did not show you the picture about the distribution of DELIs. So this is about DELIs. Here on the x-axis you have the DELIs. It is that the highest burden actually is due to 3rd generation cephalosporin resistant Enterobacteriaceae. But when you look where we are right now, with the 3 countries we reverse operates, and we can see that actually there the bulk of the burden comes from carbapenem resistant or colistin resistant E. coli or Klebsiella pneumonia. So this is really worrying, and it's just to show you that probably reverse operates in the right countries. We all know that antimicrobial consumption is a driver of antibiotic resistance. This has been shown here in this study by colleagues from Australia, modeling, doing models for European countries. And you can see here this correlation between antibiotic usage and average antibiotic resistance. What's interesting here that when you just do this univariable analysis, this explains 33% of the total variation of antimicrobial or antibiotic resistance. Interestingly, when you correlate the average antibiotic resistance to control of corruption, then you have an inverse association, which means that the higher the control, the lower the resistance, or the more corruption, the more resistance, you can say. This would explain 63% of the total variation in antibiotic resistance. Maybe this is sort of a gadgetry, but still it has a point, because it also shows when it comes to antibiotic or antimicrobial consumption, this is due to a lot of cultural issues. And for instance, if we are going to the Hofstede areas, power distance, individualism, which is more strongly correlated in Southern European countries, or uncertainty avoidance, this plays a role in how we use antimicrobials. So what about infection prevention and control measures? I think we heard the presentation by Yehuda Carmeli, who showed us his experiences with crab in Israel. There is another long story actually from Israel about CRE in especially long-term care facilities. There as well, there was a wide and large intervention in hospitals, in acute care hospitals, but also in subacute wards and rehabilitation wards of post-acute care hospitals. And they were actually quite successful. They did not achieve zero proportion, but here in the 5 cross-sectional surveys on CRE carriage in those facilities, you can see that when the problem was detected in 2008 and 2009, after some interventions, you can see here that in those repeated point prevalence surveys, the proportion of multidrug of CRE positive pathogens decreased over time. So this is rather a success story, I would say. What about antibiotic stewardship? Is it also successful? I think it is. At least what we can see in the literature is that antimicrobial stewardship has an impact on how we use antimicrobials in terms of how much we use, but also how we select antimicrobials. But a problem of antimicrobial prescription is actually much more complex than we think, because how we use antimicrobials, and this has been nicely summarized by colleagues from England, Asmita Sharani, for instance, from Imperial, has published several papers on this topic. We use antibiotics under peer pressure. Hierarchy plays a role. Uncertainty avoidance, I already mentioned this, plays a role in how we use antimicrobials. Habits, and also availability in some of the countries, maybe not so much in Europe, but still also in Europe, but certainly worldwide. Well, in summary, antimicrobial resistance is an endemic, under the radar problem. So it is not something where we live right now with COVID, where it's a slap in the face and nobody can really deny it. It is something that has emerged over time, and it's still here, and it continues to evolve. AMR is not the result of a single error in the production line of treating patients. AMR is driven by transmission and selection of resistant microorganisms and resistance genes due to breaches in infection prevention and control practices, limited diagnostic capacity and prescription behavior. And there is evidence on specific infection prevention and control, as well as antibiotic stewardship interventions working on isolated AMR challenges. On the other hand, interventions on AMR must address behavior in hospitals that are complex, heterogeneous organizations where problems rarely manifest in isolation. So a lot of challenges when you want to reverse emerging antimicrobial resistance by applying IPC measures and doing antimicrobial stewardship in hospitals. So what is reverse doing? In short, It is the concept of reverse that reducing antimicrobial resistance in acute care hospitals can only be achieved in a collaborative approach, where various activities interact together in a large clinical trial that is sufficiently powered to provide actionable outcomes. So this is what we want. We want to find actionable outcomes. The more detailed objectives are to design and evaluate an integrated modular strategy of evidence-based intervention programs that can be implemented in the clinical management of hospitalized patients in high AMR prevalent settings. So in Spain, Italy, Greece, and Romania, to design and evaluate a tailored enhanced implementation strategy versus a standard basic implementation strategy, coming back to that later, and also to apply a cost effectiveness study on the intervention programs for the prevention and clinical management of infections due to AMR pathogens. Then fourth, to develop recommendations and implementation strategies on AMR prevention and clinical management strategies in high AMR settings, and to explore transferability of the proposed intervention programs to low middle income countries. So we have colleagues from the international national ISL in Barcelona, and they try to model our findings to two low middle income countries to see whether it's transferable. And fifth, to obtain a change of the local organizational way of working in the participating hospitals and engage them actually as national and European reference hospitals. So by the end of Reverse, we hope that the participating hospitals will become national leaders in IPC practices and antimicrobial stewardship. Reverse clusters around a central clinical cluster randomized step wedge designed study in 6 hospitals in each of the 4 participating countries, and we have different interventions, and we have different scientific work packages. So in the middle here you have the hospital studies, work package 1, and then we have the 3 intervention programs, the MDS, I come to that later, IPC and ABS program. Then we work on implementation, and we do economic effectiveness evaluation. So the first one, the first intervention, microbiology and diagnostic stewardship, it applies audits to assess microbiological capacity and stewardship in the reverse hospitals, and support establishing microbiological assays to reliably identify CRE, CRAB, and CRPA in clinical samples. And they also offer internal reverse quality control programs on correctly identifying our pathogens of interest. They also support hospitals to increase the rate of blood culture sampling, because we know that if there is not sufficient microbiology in hospitals, there is a decrease of identifying healthcare associated infections. And then there are also 3 point prevalence surveys on CRE colonization in inpatients with clonal relatedness analysis and identification of resistance genes. The IPC intervention has 2 levels. The first one is to work on enhanced standard precaution measures, more horizontal measures, and also like hand hygiene with special emphasis on the use of alcohol-based hand rub, basic environmental hygiene, regular point prevalence surveys to detect previously unknown MDRO carriers, then target MDRO screening in high-risk populations, and audits and feedback on the basic IPC components in regular time intervals. Then also, where appropriate and where manageable, it aims at universal MDRO screening at admission in high-risk units, to reinforce contact precautions for identified MDRO carriers in those high-risk units, and then work on enhanced cleaning in high-risk settings, improved information transfer within the hospital along the referral pathways, organizing root cause analysis or establishing root cause analysis of newly detected cases, and more on the technical side, decolonization or decontamination of colonized patients, for instance, with chlorhexidine body wash, and where appropriate, applying molecular analysis and sequencing of isolates for outbreak investigations. Then the third intervention is antibiotic stewardship. It is a best practice program focusing on organization, structure, and available microbiology. Looks or works on adherence to national ABS plans where there are any. Then establishing multidisciplinary stewardship committees, guidance documents on syndrome-specific treatment pathways, to establish dedicated recommendations for new drugs, and local antibiotic stewardship teams with ABS rounds, and also surveillance of antibiotic consumption with detailing will be established, and also works on correct dosing in the light of the UCAST breakpoints, something we did not discuss too much in detail, but is an issue sometimes in how antimicrobials are dosed. And technical interventions, screening of patients in high-risk areas, and personalized surgical prophylaxis. Then there is this intervention part, this implementation part. This implementation part actually is a hybrid implementation effectiveness trial, because we will offer implementation support to all hospitals. First of all, we do an inventory and we assess the readiness for implementation generally in the hospitals, which is basically is mapping the different contexts, like the in-hospital, the outer context, which means that the country, but also then what is implemented, how is it is implemented, and then the organizational culture. Then we will offer enhanced implementation support to some of the hospitals, to a randomized subgroup of the hospitals, and we will try to understand if such enhanced implementation support, which will include basically going on site and elaborating or designing a much more tailored implementation program with some of the hospitals, if this can make a difference, something that has never been done actually in our field. Then there is this cost effectiveness analysis, which will start, first of all, not with an analysis on the data of reverse, but with a systematic review on cost effectiveness of diagnostic stewardship programs, IPC and ABS programs, and then focuses on microcosting of interventions and implementation, quality of life estimation, cost effectiveness analysis from hospital perspective, but also cost effectiveness analysis from a societal perspective, which is not the same. And also, finally, I mentioned that extrapolation to low and middle income countries of the findings of reverse. So the reverse consortium has 12 partners from 8 different countries. And we have 6 hospitals, each in Greece, Italy, Romania, and Spain. The coordinator or the coordination site of reverse is the University of Zurich. And also to mention is that reverse is one of the independent partner projects of eCRADE. So thank you very much for your attention. And now I hand back to Sasha, and we have some minutes to have a discussion. I have seen that some of you have already submitted some questions. Thank you very much.
Thank you, Walter. Yeah, we have around 10 minutes left now, where we can go through the questions that have been posted in the chat. We start just with the first one, which was written during the time of Mark's presentation. So maybe Mark, it's probably a question for you. Do you think the difference in methodology used in testing within European Union countries has some influence on results on resistance?
Yes, certainly it does. I mean, not just antimicrobial susceptibility testing, but microbiological testing in general, and case ascertainment. We know there's a tremendous variation across EU countries, and that's been illustrated by the results of the point prevalence survey on HAI that Walter has referred to, where an indicator of the intensity of testing, such as the blood culture use, can explain up to half of the variation in the prevalence of infection. So it's a tremendous effect modifier in what we actually report and detect. It's really how well we ascertain infection to begin with, especially some difficult to detect infection that require more proactive screening. For instance, CDI is well known in some countries to be very much under tested and under detected and under reported for that reason. And also, when we're talking about difficult to detect resistance mechanism, for instance, colistin resistance, even in labs that support and claim following UCAST guidelines and breakpoints, half of them cannot detect properly colistin resistance from external quality assessment surveys. So we're still in trouble. So some of them really require advanced diagnostic stewardship to resolve these issues of under-testing and mistesting. Over.
Thank you, Mark. I hope that answered your question. Then a question for Yehuda. CRAB, how is the situation changing over the time?
The situation of CRAB. I would say that what we have witnessed in Israel is a sharp rise in the late 90s, early 2000s in Acinetobacter baumannii, and I would say that in the early 2000s, about 60% of the isolates were susceptible to carbapenem and 40% resistant. And what we have seen is, I would say mostly with starting, and I cannot test for the entire country. I can say at that time, I had only data from Tel Aviv. What we have witnessed that once we started to implement more and more infection control measures directed at Acinetobacter baumannii, what we have seen is convergence of strains, reduction in number, but mostly we were able to affect the multi-drug resistant but carbapenem susceptible clones, which almost disappeared, and the carbapenem resistant clones have remained and continued. So although so that was the initial. So we, in a way, we got rid of our carbapenem susceptible multi-drug resistant Acinetobacter baumannii. And if you look only at percentage of resistance, it seems that we got worse, but really we got better because we eliminated the susceptible. The continuous fight with the carbapenem resistant organisms, I would say from about 2010 so forth, we continue, we see on initially a stabilization at about, and since then a slow decrease, a constant decrease over time, and we are about 50% of what we were 5 or 6 years ago in terms of incidence. But we still, and we have some hospitals that, well, I wouldn't say eradicate, but they had rare events now of outbreaks of multi-drug resistant Acinetobacter. But most hospitals continue to have ongoing problems, and it's an ongoing problem. In few hospitals, I would say it's almost non-controlled outbreaks, and we work with those hospitals to move into cohorting. Just 2 or 3 months ago, we intervened in a hospital where they had multiple outbreaks, and they felt it's beyond their ability to deal with that. And we convinced them to cohort the patients. And they say it's too, we have too many patients. We cannot cohort all of them. It disables our ability to operate and so on. And we worked with them to start it at the time that they have a low. They waited until, by chance they have a lower number, and then cohorted the patients. And since then they have a much lower incidence. But that has to be combined with multiple other effects, interventions, and especially enhancing environmental control. It's so crucial to have good environmental control for controlling carbapenem-resistant Acinetobacter, and that's a weakness in many of our hospitals. It's improving over time, and I'm sure it will get better.
I think the next question you kind of answered already in your presentation. Do you advise some measures to minimize scrap? I guess, I don't know if you want to add something to what you presented.
Yeah, I want to add on the importance of screening and detecting carriers. In some setting, when you start doing screening, you find that many more patients, similar to many other or multi-drug resistant organisms, are truly unknown. And if you don't identify them, your infection control measures may fail, and you may be very disappointed and say nothing works, but truly you didn't direct it to the right patients. Second is environmental cultures. I don't think you need to do environmental culture on a routine basis, but you have to do it from time to time. You have to have this, it helps you to direct your efforts. It helps you to find that you are not where you have failures, and it helps you to examine how good is the quality of cleaning. And many times or most of the times you're surprised how bad you are. And that's, I would say, quite helpful, because it's eye-opening and helps direct better efforts.
We have two more questions also in the chat, Yehuda, for you. How about the rapidity of development of CRAB, and what is the future of treatment of CRAB?
I'll speak about treatment. I think there are few companies now that are trying. I think that's in many ways we don't have any good treatment for CRAB right now. The two, I would say, agents that are available are colistin and cefiderocol. Colistin, I'll say it, not gently. It's a terrible drug. It's not effective, and it's not safe. However, we use it because we have nothing else to do. I would, be even more challenging than Mark was. I would say that almost no lab provides real-time good results for colistin susceptibility. So even those who know how to test don't do it on a routine basis, and if they do it very late. So colistin is, the best we have, but it's terrible. And second is cefiderocol, and cefiderocol, I would say, is its efficacy against Acinetobacter baumannii, especially in pneumonia, is very questionable. And I would say most people don't go for it. There are now several agents under development. One of them, I think, even completed, the Antisys product just completed a successful phase 3 studies. I haven't seen the entire data, but I read the press report. So I think we will have few agents. I think I'm sure it will be quite expensive and will not, I hope we'll have good agent, but I'm not sure how widely available it will be to use on a regular basis. So what further for us? Well, on the other hand, I would say that Acinetobacter baumannii now remains the most attractive target for drug companies because they don't have any competition. Whatever they will develop will work. If they are successful, they will be the only one on the market. So yet, the question is how willing will be facilities to pay the price for this development, which is quite expensive.
Thank you, Yehuda. We have one final question. I know we're already a bit over time, but since it's one left, we can maybe answer it hopefully quickly. So it's a question from Pablo Ruiz, who is a Spanish student. So he's writing his final degree project, a systematic review on the use of bacteriophages in the treatment of infections caused by MDR bacteria. So he actually asked Yehuda and Walter just your personal opinions about the subject, and if you think using these agents would have a significant impact on the treatment and prevention of such difficult to treat bacteria, for example, crab, in the future. I don't know, Yehuda, if you want to give you.
So it's bacteriophage.
Yes.
Yeah. So I think bacteriophage have a great future, but I think so since I was a medical student, which was a long time ago. And nothing has changed since, and I'm not very optimistic it will.
I don't know, Walter, from your side, anything to add to that?
No, I totally agree. I think I'm a bit younger than Yehuda, but it's exactly the same story. I mean, bacteriophages are around since ever, and it's difficult to imagine what is the game changer right now? What will be the game changer so that this treatment, those bacteriophages will be available on a routine basis to treat MDROs. I'm still happy to see when it happens, but I'm really not sure that this is due so.
Okay, thank you very much. So there was just a small question, which was actually more for me in the end. Maybe I can finalize with that. So this is our last slide here. Obviously, Reverse is a project that just started a few months ago. It will run until 2026. You can follow our progress on social media. So we have a LinkedIn and a Twitter account. Just look for Reverse H 2020, and also by early January, we will have our project website at reverseproject.eu. So please follow our updates. Also on the social media accounts and then the website, we will also obviously share this the recording of this webinar. And from my side then, I would like to thank everyone for participating and also for the interesting questions, and obviously for our speakers, thank you very much for the interesting presentations, the preparation, and also the answering of the questions. So thank you, everyone. And I would close then the webinar. I wish you a good evening for those in Europe, and all the best. Thank you.
Thank you. Bye.
Thank
Bye.
you.
Thank
Bye-bye.
you very much. Bye-bye.